Welcome to Toxland. We're your hosts, Jesse and Bree, two besties on a mission to shake up the beauty industry from the inside out. Say goodbye to self-help overload and hello to our cheeky and unfiltered take on being a babe in a toxic world. Let's get toxic.
Welcome back to this week's episode of Babes in Toxland. This week we have some very exciting guests, Dr. Bill Portuese and Dr. Joe Schvidler. We are so excited to have you here. Thank you so much for coming to visit us after your insanely busy day of facial plastic surgeries. How was your day? Tell me everything.
It was great. We saw lots of patients today. It was wonderful. See some new consults and follow-up visits. We do both here. I love coming to Portland. I love to do some sightseeing and go to Voodoo Donuts. I love the location to Seattle now. But and in the summer, I'm going to bring my daughter here because she loves Portland. Last time came here, she loved it. She's a figure skater, and we actually have had some competitions here in Sherwood, but she loves it here. So maybe we'll even do a trip to the coast.
Yeah, that's definitely only in summer.
Yeah.
So you guys are primarily based in Seattle, and you come to Portland once a month.
Correct. Yes.
Correct. Okay. And you just provide your amazing services to us Portlanders. So we're doing consults, we're doing surgery, and we're doing follow-ups.
Correct. But the surgery itself is done in our Seattle Surgery Center.
It is?
Yes.
Okay. Oh, I didn't know that.
There's a lot of, what's the right word? There's a lot of moving parts to building a surgery center, design, build, construction, management, the staffing, the anesthesia providers, the nurses, and it's an expense that is significant. So we only have one surgery center, not two.
And you own your surgical center.
Correct.
Yeah, that's amazing.
Yeah, that's a big deal.
Yeah,
It's a
it's
big
pretty
deal.
rare, right?
I want to hear a little bit about both of your backgrounds, how you came to be facial plastic surgeons.
Yeah, so I started my career in the military, actually. I was trained in Hawaii in a military residency program. That's where I got my first love for facial plastic surgery. I was fortunate enough to spend studying rhinoplasty, both functional and cosmetic. We did offer cosmetic surgery in the military. There was a little program where we were able to offer family members, retirees, some cosmetic surgery. So I got...
For deviated septums?
No. It was functional and cosmetic both. So that was a great little perk in the military that family members had and active duty military members. And so that's why I did my first 120 rhinoplasties, and they were all closed. So my journey to rhinoplasty started in the military. Then I went on to do a fellowship in facial plastic surgery at University of Washington hospitals, and then I was taught about the open rhinoplasty. So next 100 or so cases, I studied learning open. So I was able to see the anatomy. Didn't really understand at first a lot about the approaches and the different anatomical parts. So I had to spend some time learning about the open approaches. And then I kind of took that on and I did open rhinoplasty for a very long time. So for the first probably 10 years of my career, I was doing open rhinoplasty.
Wow.
I was teaching residents at a military hospital in Tacoma, Washington. And once I left the military, I went to a private multi-specialty group and spent the next 8 years there. So I've been practicing for 18 years now.
Wow. And
And the last 3 years I've been with Bill at the Seattle Facial Plastic Surgery Center and doing exclusively closed rhinoplasty. So that's about 98% of the time we do closed rhinoplasty now.
okay, so I'm super naive to rhinoplasties. I actually don't know the difference between open or closed. Tell me everything.
Go ahead.
Well, open versus closed is just an approach. It's not what we do inside, it's how we get there. So with an open rhinoplasty, you have to make an incision across the bottom of your nose or the columella. And then all the other incisions are placed inside your nose versus with a closed rhinoplasty, all the incisions are buried inside your nostrils. So there's nothing open, with a small exception if somebody wants to narrow their base of their nose. We sometimes will put small incisions on the sidewall, on the base of the attachment of the nostril to the face to cinch the nostrils down. That will be the only outside incision, but everything else is done through the inside of your nose. So patients ask, like, what do you actually do? How do you get to structures just through the closed approach? Well, we make small strategic incisions and we create strategic tunnels where we can actually insert our special
the
instruments
nostril?
through the nostril.
All through the nostril.
All through the nostril, and we can actually see the anatomy. But a lot of it is also feel, too. It's a feel surgery. It's see and feel surgery. And it's kind of like a dying art now. There's not a lot of practices out there that perform closed rhinoplasties. Really? So I feel like we're like one of the few practices in the Northwest that are still carrying the torch.
Wow. Fascinating. Dr. Bill, Dr. Portuese, tell me a little bit about your background and how you've come to be this successful plastic surgeon that you are.
I sort of the same line of training that Dr. Schvidler has done, which was I grew up in Oklahoma. I did my ear, nose, and throat surgery training in Louisiana, and that's where I did 100 rhinoplasties my chief year. And I thought I did a lot until I met this guy. He did more than I did as a chief. But 100 rhinoplasties as a chief resident is a lot. 125 is even more.
An average resident graduates and with 5 rhinoplasty in plastic surgery residence.
5.
Yeah.
That's
Correct.
actually terrifying.
5.
Yeah, you said those numbers, and I was like, that sounds about right.
Yeah.
Yeah.
That's scary.
Yeah.
So 5 rhinoplasties and you're ready to go operate on the public.
Yeah.
That's terrifying. Okay.
Well, I can tell you, just step that back. I tell patients that it really takes about 1,000 noses and a decade of experience to be really, really consistent at this procedure, rhinoplasty procedure. And whether it's closed or open, it takes about 1,000 noses to get really consistent. Anyway, so I did my ear, nose, and throat surgery residency in Louisiana, and then I did a facial plastic surgery fellowship in Beverly Hills, California at the famous Lasky Clinic.
Oh, yeah.
And moved up to Seattle, set up private practice, and been practicing ever since for the last 30 years.
When you
What
first
year did you move to Seattle?
1991.
I love it.
When you both first got into the medical field, you knew you wanted to be a doctor, I assume. Was it always, I know I want to do plastic surgery and facial plastic surgery, or did you have a different trajectory when you started?
I thought I was going to be a pediatrician or a family practice doctor. But once I got into medical school, I really liked the anatomy. I was teaching anatomy in college as a technical assistant in the labs, but I really loved the anatomy. And then I really started liking and loving the anatomy of the head and neck. And that's when I decided, I knew I wanted to, at that point I said, well, I may want to do plastic surgery, because at that time we were doing a lot of reconstructive work. So car accidents, knife and gun club, pool cues over the head, knife lacerations and ears torn off and all this kind of stuff, and trauma. And then I decided about the middle of my residency, I really wanted to do plastic surgery. So then after my ear, nose, and throat residency, you kind of had 2 choices. One, you could do the whole body plastic surgery route, or you could do the facial plastic surgery route. And that's what I did, the facial plastic surgery route. Actually, he did too. And then just went into private practice. But here's a funny story. So like, while you're talking about rhinoplasty being a difficult procedure, when I did 20 or 30 of these rhinoplasties, and I just couldn't figure out how to do the osteotomies where we narrow the nasal bones. And I kept asking questions. I was talking to my instructors, and the chief of the department said, okay, Dr. Bill, go down to the operating room, grab the instruments for the rhinoplasty instruments, and meet me in the cadaver lab tonight with the other chief resident. Okay. So we went down we broke into the cadaver lab, and we literally got the hammer and the chisels out, and we broke every single nose of every single cadaver in the lab.
You guys need to explain what cadaver is. I believe it was
Dead person.
Dead person.
You did nose jobs on dead people.
Exactly. I just had to figure out how I just couldn't get my arms right, because you can't see it. All you can do is feel it. And once, I don't know how many broke, 50 or 60 or 100. Then I realized, that's how it works.
That's how you learn. I mean, that's so in medical school, you have to spend your very first class of medical school. You have to spend 8 to 12 weeks, depending on which medical school you go to, in a cadaver lab. You literally live there from 7 o'clock in the morning till midnight, probably, because you're either in didactics or studying anatomy. It's a very condensed course, but you're assigned a person who's donated their body to the health, to science, and it's very appreciative, because I mean, it's how we learn anatomy as medical students and surgeons, and I fell in love with just studying the anatomy, and I think that's kind of what drew me to become a surgeon. And head and neck anatomy is the most complex anatomy in human body. Probably pelvic anatomy is the second most complex, but that's what I think kind of drew me to become an ear, nose, and throat surgeon, and kind of drove me that route. I think there's an artistic component to that too. So I think myself having an artistic background, I study art and painting. I think those two things have really kind of drawn me to become a facial plastic surgeon.
Yeah, that's always my question for surgeons. Do you have any artistic background? Same thing for injectors, because typically you do, right? You typically have a love of arts or passion.
I've always loved to draw, but like my preceptor in residency told me, you need to go take some art classes. If you want to do facial plastics, you need to go to a studio or and take an art class, take a facial analysis drawing or body drawing and stuff like that. Just learn the proportions, because you really have to have the aesthetic and understanding the proportions of the face, the nose, etc., to really have that gestalt of what looks good. Some surgeons actually measure things. They can take out protractors and measure angles, and they're very technical about it. Some people use tools like computer imaging to measure certain proportions of the face. There's that, the golden ratio, and there's all kinds of studies about that. But I think if you
that mid-surgery?
Some of them do. Some of them take out protractors and actually measure the angles. We don't do that. I think for me, it's more of a gestalt of just seeing analyzing the face before and after. And we kind of can delve into that a little bit later, but we use image simulation software to help us with that as well.
Yeah.
Yeah.
I have a couple of questions about closed rhinoplasties. So, number one, who is a good candidate for a closed rhinoplasty? And number two, what are the key benefits of doing it that way?
Just about anyone is a candidate for closed rhinoplasty. So, yes, if you're on your third or fourth rhinoplasty procedure, and there's some of that, and there's been an extensive amount of scar tissue and grafting, and there's no cartilage left, this and that, and the dissection planes and the whole anatomy is all really a ball of scar tissue. Okay, you could make the argument an open rhinoplasty could be performed on that occasion. But Joe, you talk about the advantages versus the disadvantages of open versus closed.
Yeah, if I'm your patient, why would I want a closed one versus an open?
Well, I think first of all, it's if you're a really scar conscious person. Like if you don't want a telltale sign of an open rhinoplasty, a scar across the bottom of your nose, that would be probably the biggest thing. Because even though the scar could be very well repaired, it could be hidden, it's still there. It's always there. The other thing that happens, and I've personally found that I can always speak from my own experience because I've also done a lot of open rhinoplasty in the early part of my career, is that when you deglove the nose, you can create a lot of secondary problems later on. They can come up later on. Your skin soft tissue envelope can contract quite a bit afterwards. And so what we do in open rhinoplasty, we put a lot of supportive grafts to counteract that effect. And as a result, your nose can become a little bit stiffer because of that. The bottom, we see a lot of the stuff you would test that. We see a lot of dropped columella or hanging columella as a result, as a byproduct of an open rhinoplasty. There's also some issues with wound healing. First of all, you have to cut through the blood supply. Columella actually carries arteries, veins, and lymphatic channels and nerves that supply blood supply to the tip of your nose. So if you cut that, you're losing some of that blood supply. So there could be some healing issues with the tip. And so patients with a thicker skin are really good candidates for closed rhinoplasty because the healing time is a lot faster. Your downtime is a lot faster than with an open approach. You can get some lymphedema, which is a swelling of the tip of your nose. So that's not a consideration. So again, it's just an approach. It's not what we do underneath. And we still modify the cartilage and the bone underneath. We still use grafts. We can put all kinds of grafts through a closed approach that we can put within the open approach. So in the older days, I would say the limitations used to be, we can't put this type of graft. We can't put a spreader graft because it's just too difficult. Well, we've overcome that. We can put spreader grafts in there now. Well, you can't put a caudal strut, which supports the tip of your nose. Well, we can do that with a closed approach now too.
We did one yesterday.
Yeah. So we we can do most of anything we can do with an open approach. The only situation I would say I use an open approach for, like Bill said, complex revisions. If somebody's septum or anterior septal angle is way too off, if that's really weak and deviated, and I have to do total septal reconstruction, a lot of times I have to do an open approach just because I have to get large pieces of cartilage through the tissues. So then in that situation, I'll use an open approach. But like I said, 90% of the time we use a closed rhinoplasty approach.
We've also seen from other practices, we've actually seen the entire columella and tip necrose.
Oh, totally.
From a lack of blood supply, and it's dead. Yeah. Now you need whole another reconstructive procedure, such as a forehand flap, to get to reconstruct that. That's a
those are the things we see on like botched.
Those are disasters.
How often do you see that?
I've seen 2 or 3 in the last 10 years.
Okay. The other monkey in the wrench is the revisions. If you have multiple revisions, now the fillers are being used in the nose, and that can compromise the blood supply, and so it's tricky.
Yeah.
It's not the rhinoplasty of 20, 30 years ago.
Right.
It's there's a lot of variables there. Yeah.
So I've had 2 open rhinoplasties and a lip lift, so I've got a lot of scars going on right there. But something interesting that I've experienced is I have like a shooting pain that also goes kind of numb on the tip of my nose. And it bothers me. And it's definitely something that it was not there before.
So neuropathy is another thing that people don't talk about, right? So you're cutting off the nerve endings here. So with the closed rhinoplasty approach, you're still separating some nerves, but you're not compromising the main blood supply and main nerve supply to the tip and the columella of your nose. And so that's what people don't talk about, these secondary autonomic issues. We see a lot of redness in the nose, difference in the sweating, how your nose sweats afterwards. I've seen people complaining about, well, my skin is more oily now after open rhinoplasty. I have more redness, more glandular.
Yeah, I have a red line all kind of right through here that I have to considerably cover with makeup on this side of my nose.
Yeah, so usually with a closed rhinoplasty, the nerves regrow back after about 1 to 3 months. And the reason we know that because we do steroid shots, and at even 1 week or 1 month, people don't feel as much because it's still kind of numb.
Correct.
And at 3 to 6 months, they feel it because the nerves do come back. With the open rhinoplasty, it can take a lot longer for those nerves to grow back, and sometimes they may not. You can have what's called synkinesis, where the nerves crisscross and the nerve heal in a wrong way. There's synkinesis with the motor nerves in the face, from facial injuries, but you can also have sensory, essentially, denervation, cross-wiring, where you have altered sensation in there. You can have creepy crawly sensation, anxiety,
an ouchy nose for the rest of my life. And this is what it is, right?
Well, hopefully, long term, some of it will recover, but it may take several years.
Yeah, I think the last rhinoplasty I had was in 2017.
Okay, so it could be permanent.
Yeah. Well, price you pay for.
Yeah. Unless she comes back and sees you guys.
Yeah. See, I'm trying to put you on for a challenge. Who wants to do rhinoplasty number 3? I'm a surgeon's nightmare. I want to address some common concerns.
I love your nose, Brie.
Thank you. I like it from certain angles. This one, dead on? No. Okay, so let's address some common concerns. I hear it a lot in my friend group. I hear it a lot in clinic. It's the bulbous tip. What do you do with that? How often are you hearing complaints about that? Do you like working on those? What do you think?
The bulbous tip can be caused from 2 different issues. Thick skin or just wide cartilages. When you have thick skin, there's really not much you can do. And because the rhinoplasty, whether it's open or closed, it just involves sculpting the bone on the cartilage. Mm-hmm. If you have thick skin, it's like wearing a parka rather than a wet T-shirt. I mean, but if you have thin skin, everything shows through. Mm-hmm. Thick skin, nothing shows through. And no matter what you do underneath thick skin, it doesn't matter. It still looks the same. Mm-hmm. So as long as the patient's a good candidate, they have medium thickness, thin or medium thickness skin, we'll go in and reduce the bulbousness of that boxy square tip by a conservative removal of some of that cartilage in the tip itself. Mm-hmm. And then depending upon how boxy it is, sometimes we'll actually put these little stitches in these 2 tip cartilages just to narrow from a a wide boxy tip to more of a triangular tip. Just a more refined.
That makes sense.
Still your own cartilage, is just instead of being square and boxy, it's just more pyramidal shaped. And so this combination of sutures and a conservative cartilage removal usually will refine that bulbous nasal tip.
Okay.
How
Interesting.
often do you dream about rhinoplasties?
I don't really dream about it. It's because I deal with it every day.
So does it ever because it's probably like second nature to you.
You wake up at 4:00 in the morning. Oh, that's a good idea. Well, it's all like, yeah. What about that? Oh, yeah. You come up with just a little pearl of wisdom. Oh, yeah, yeah.
Yeah, and then do you ever implement it? Like, what has come to you at 4 a.m. that's like been a star?
So tell me about, I think this is probably a very common patient complaint, but a crooked nose and how you approach that and what you do.
Crooked nose is usually a combination. It's probably been broken, or the patient came out of the birth canal cockeyed and it just kept growing cockeyed. But, people fall off their bicycle at 3 or 4 years old. Well, the growth plates haven't quit growing, so they grow crooked. Mm-hmm. Same way with deviated septum, right? So 9 times out of 10, when you see a crooked nose, there's a deviated septum component with blockage of airflow.
Is that what it is? I thought it was from doing so much coke.
That's only in LA.
I don't remember a nose injury, so I was like,
What we do to straighten the crooked nose is we have to reset the nasal bones with what's called medial and lateral osteotomies. That's resetting the nasal bones here.
You use like a hammer and a pick?
Yeah.
that's what you did on the
Hammer. It's a little tiny chisel and a little tiny hammer and tap, tap, tap. We make little tiny cuts in the bone and then straighten it around.
Is that what makes people's eyes black from the trauma of you like hammering the bone?
Yeah, but we've got a few little tricks up our sleeve.
Yeah, that's kind of on that way.
Injections. You use now a medication called TXA, tranexamic acid. That is a game changer. It really significantly reduces the amount of bruising after a rhinoplasty.
It's great for melasma too.
I just got way too
Yeah,
early.
topical, right?
Yeah. And oral actually.
And oral, yeah. Well, that's my wife actually brought me into this. That's actually a really cool story. You want to hear a cool, funny story?
Yeah.
So I early in my career, I did a lot of ear, nose, and throat. So I worked in the military, and then I was in the multi-specialty group, and the bane of my existence was call.
Being on call.
Being on call.
Being on call.
So, and what is the most common ENT problem at 12 o'clock at night? Is nosebleeds.
Oh.
Epistaxis, yeah. So you get a call, and you have to go in and take care of these patients because it's an emergency. And so, yeah. And so my wonderful wife is an OBGYN, and she's been using this little medication called Lystata or tranexamic acid in OBGYN for abnormal uterine bleeding and during the surgery when they operate on the uterus and stuff for years. It's not a new medication. It's been around forever. And she's like, well, why don't you just have them give the patient IV TXA and, have them follow up with you in the office in the morning. So I said, okay, well, I'll try that. So I asked for that, and I said, well, call me back if the patient's still bleeding. I'll come in and stop the nosebleed. Well, 10 minutes later, the ER doctor calls me back and says, the bleeding has stopped.
Oh, that's cool.
I'm like, okay, that's
Thank
cool.
you to your wife.
So then I started using it, and it cut down my rate of going in, on-call rate going in and stopping the nosebleed by 40%.
Wow.
The worst thing the patient wants is a tampon placed outside the nose.
Awful.
Because it's awful. It hurts like holy hell.
Well, in the old days, we put 6 feet of gauze in patients' noses. The people still ask us about that.
themselves.
They come in for a nosebleed?
Oh, yeah.
That's okay. So when I was little, I would get constant nosebleeds, and I had a nanny who was like an older Hispanic woman who would lay me on the ground, and she would kick the shit out of the bottom of my feet. What? She would just toe punch the bottom of my feet.
Face down or?
No, on my back. And she would just like that. And kicking, and my nose would stop bleeding.
Yeah.
Yeah. It's the weirdest thing.
I love it.
Yeah. But it was basically the same difference. Yeah.
Anyway, so we use this routine. So we started using it in sinus surgery, routine nasal surgery, and it's really cut down on the bleeding, intraoperative bleeding, postoperative bleeding, and bruising. The bruising has been a game changer.
Amazing.
Half of our patients don't bruise at all. So we have a whole protocol. We have them take arnica montana or Cinec.
Yeah.
Before surgery, they have them do vitamin K and bromelain, or just eat lots of pineapple.
Yeah.
Which are well known.
We even, suggest those things to our injectable patients.
Absolutely.
Yeah.
Wait, so how are you applying the transendemic acid for surgically? Like, are you?
It's a good question. So you can either give it IV. The nice thing is it has very similar bioavailability. You can give it orally. Like, for example, even if you have a patient you need an injection and you know they're a big bruiser, you can actually give oral Lystata.
This could change the game.
It's off-label. It's huge. You should try it. I'm telling you.
What are the risks?
Give you
Like a blood thinner? Or
no, it's
thickener?
it's thickener. Yeah. So you probably don't want to give somebody that has history of stroke and this is not medical advice. This is just
Off-label.
This is off-label use.
We're going to be doing that for lip filler.
Yeah. So it's really cut down on bruising and bleeding. So
We use it in the injection.
and we can use an injection. Yeah.
Oh, no.
When we inject around the nose, we put it in here, so it's right there locally.
I was going to say, do the majority of your patients go under general?
Yes.
Yeah.
So they're out. They're bye-bye.
Yes.
Yeah.
What about tibplasties?
Most patients can't tolerate.
Yeah.
It's not the surgery; it's the injections to get the tip numb. It's a minor little thing, yes, but you're trying to do bone work and cartilage work and or septoplasty work, or you need a cartilage graft. You've got to do you really have to be put to sleep under general anesthesia.
One other thing I want to mention about the crooked nose or deviated nose is that there's also facial asymmetry. So I always tell patients you may have some underlying facial asymmetry, and that's causing a nasal asymmetry. So think about a house that's built on uneven ground. For example, a Tower of Pisa is just off 3 degrees. So if you're close on that first, second level, you don't see that deviation. But if you're far away,
You see it.
it's a tall structure, you see the deviation. So we use that geometric illusion to our advantage by making the bridge a little bit lower. So if your bridge is closer to your face, it makes the deviation less pronounced. But I also tell patients there's limitations as to how much we can fix your asymmetry, because everybody has a right and left side of the face. And if the plane of the face is uneven, if your house is built on uneven ground, then the roof of the house is also a little bit uneven. And so we have some tricks to mitigate that. But if you really look in nature, everybody has a little bit of asymmetry, and that's normal. It makes it unique.
Yeah.
If you mirror image right side, left side
They
of
look
the
kind
face,
of weird.
or look
People look
weird,
kind of
yeah.
strange.
So that's
Yeah, I've seen a lot of different simulations of that on social media and stuff where they'll take someone like as beautiful as Kim Kardashian or whomever, and they will, take one half their face and make it perfectly symmetrical, and they look very strange.
Yep.
Like very weird.
Yes.
So it gives me some solace, because a lot of times, especially like as we're podcasting and I'll watch these videos back, I'm like, I'm so asymmetrical. Like my mouth's going like this side of my face jets out like this, and I just want to be symmetrical, but it would probably look really strange.
It's a conversation I have to have with patients a lot. With I bet injectables, they're everyone loves kicking themselves apart. Everyone wants to be perfectly symmetrical. When in reality, no one sees that except for them.
Right.
I tell patients, it makes you look unique. So just don't. There is no perfect symmetry.
Yeah.
What would you say is the most challenging part of your job? It's a consultation, holding hands after.
I think surgery is the easy part. It's the fun part. Once we're in the operating room, that's what we love and enjoy. I think it's level setting expectations and really understanding what the patient wants and trying to explain to them what could be done and could not be done. I think that's the hard part about surgery in general. Plastic surgery is picking the right candidates, making sure that what they're asking us to do is achievable. And the hardest part is sometimes saying no to the patients. And so
When is it a hard no? Like, what would I have to say in your chair where you're like, I'm not touching you?
Well, that's risk versus reward. And if the surgery is too risky and you don't think you can get a really good result because there's, you've had 3 or 4 procedures already and now the whole nose is a ball of scar tissue. No matter what you do, it's still going to look like a big ball of scar tissue. So the patient, you're not going to have any changes because it's just the skin shrink wraps over this cartilaginous framework. And especially if somebody's had a rib graft, done in the past, it's like breaking through concrete. So if somebody's had a rib graft in the past, it's like trying to operate on this wood table, and it's just not going to happen. So I don't operate on anybody. I say no if anybody's had if you've had a rib graft rhinoplasty, that's your last procedure.
So what's your favorite okay, 2 questions here, 2-part. What kind of procedure outcomes require a graft from another part of the body, and what's your favorite place to take a graft from?
Well, we always use nasal cartilage first.
So you start with what you've got.
Always
right
use
here.
nasal cartilage first. So, and the most common of those grafts that we use is something called a spreader graft. And those are placed right along in this area right here. So when you take a hump down, you destabilize the bridge line just a little bit. And these cartilages, not the bone, this is bone, right here in the mid portion of the nose, those upper lateral cartilages will destabilize once you take the cap off or the hump off, and they'll want to kind of come inward. So we put these little tiny spreader grafts, or 3/4 of an inch long and about 2 to 3 millimeters wide, just to support that. It's like a prophylactic. And we probably do that 80 to 90% of the time, because otherwise it'll be too pinched here in a year, 5 years down the road. And I tell patients, if I tell them about it, but I said, if you didn't know this, you wouldn't even know I put a graft in there.
So if there's nothing there in the nose to grab from, where else are you taking cartilage from?
Second one would be a piece of ear cartilage from behind the ear.
Yeah.
And
Yeah, the back of my ear is definitely missing. It's in my nose.
Yeah, the ear cartilage is not as strong, but it's still a good viable option. And we use a technique called lamination. So imagine a laminate or engineered floor. It's made out of really thin strips of wood that are very flimsy. If you take apart all the laminate, it's very flimsy. But if you put it together and stitch it and glue it together, it creates a pretty strong construct. So I am still okay with using ear cartilage a lot of times because your nose is supposed to be soft. It's not supposed to be like really stiff. And so while you can get a great result with the rib graft, feeling the nose, it becomes very stiff. And some patients don't like that, just to be super stiff. So I still use frozen cadaver rib grafts for some cases when I have their cartilage. Yeah. Irradiated rib grafts have not panned out very well. So there's different ways where the grafts are processed to make them sterile and make sure there's no cross-reactivity with the immune system. There's no any condition that can cause transfer of any kind of icky stuff.
Yeah.
They obviously test patients, the companies that sell these cadaver products.
What a business. They sell someone else's art.
Yeah.
I have a cadaver question, and this is going to sound super naive. Do they have to have the same blood type?
No.
Is the blood cartilage?
Blood's gone. There's no blood in the cartilage.
Cadavers, like, do they smell?
But there's still DNA in there.
No.
Of the cartilage. Like, there's still DNA in the cartilage. Right?
So they process, there's 2 ways to process the cartilage grafts. One of them, they used to irradiate the grafts. So they actually blast them with radiation. And I think that kind of destroyed the cartilage viability because there are some chondrocytes or cartilage cells that live and support the cartilage cells. But the cartilage itself, the tissue is hyaline. It's collagen basically, and other materials. It's fairly acellular. There's not a lot of cells within the substance of the cartilage, and there's also some bone tissue. So older person. So people who are not candidates for rib cartilage grafts are usually older folks who have calcifications in their ribs. So folks in their fourth, fifth decades, a lot of times are not candidates for rib grafts. Usually rib grafts, if you're going to harvest a rib graft from somebody, you have to do it like in their 20s and 30s to be good. The other problem that not a lot of people talk about is warping. So the cartilage grafts can warp. So imagine the rib cartilage. Yeah.
Specifically. Okay.
So we're specifically rib cartilage. So imagine.
It doesn't work.
Do you ever go to a hardware store?
Oh, yeah. Every day.
So you
Once a week.
The 2x4s,
Yeah.
some 2x4s are really nice and straight, and some of them are bent and curved. That's because when they cut the wood, they take the wood from the periphery of the tree, and those are the ones that bend a little bit because the trees grow concentrically. They go from inside out.
Concentrically.
Yeah, so the term concentric means from growing from inside out. So the rib grows concentrically as well. It grows from inside out. And so when you cut the rib, the outside of the rib tends to warp. So you have to kind of soak it in saline for a long time to see if it warps and shape it. And so when you put a graft in, it may look great for 3 to 6 months. And then you come back and then you have, a nose that looks crooked because that rib cartilage has warped. And so the main downside to the rib grafts. We still use them in certain situations. Like I like to use them for spreader grafts when there's no other tissues. But you have to be careful and you have to use some innovative techniques to minimize the warpage. And so, just like Bill said, my go-to choices are septal cartilage first, if it's available, then ear cartilage, then rib.
Gotcha. It's so fascinating because my husband works with wood, and he, has clients just like you guys do that are upset if it looks great for 6 months and then it cracks. And it's just like, and it's always the exterior portions.
Right.
So he has to set those expectations too of how, well, this is a natural material. It's going to change over time.
Right.
And, we just don't know. And then they still always come back to him or they're mad at him.
Oh, wow.
But I'm sure you deal with the same thing.
Yeah.
Let's talk about the patient journey. I think a lot of our listeners may potentially be interested in rhinoplasties, and I want to talk about what that might look like for them.
So I'm interested.
Yeah, let's bring it back to me and Jesse again. So let's talk about what your consultation process is like and how you level set expectations.
So the first part of the consultation, we want to make sure the patients are healthy. They're not on a list of medications. They don't have any issues that we might not be able to put them to sleep under anesthesia. You got to be healthy. Right. Mm-hmm. And you have to have a BMI in our facility less than 32. You cannot be morbidly obese, having elective surgery on the airway. And so then we look at the nose. We take pictures. We do computer imaging to try to show you pretty close to what the nose will look like.
Oh, that's pretty cool.
Before and after.
It's like, take my money.
And then what we do is talk about, I ask, what are your concerns? What do you want to do? What's your goals? And then I kind of formulate with a mirror in place. We talk about, okay, we're going to, and we go through I break it down into specifics. Your dorsal hump, we're going to shave that down. We'll give you a nice minimal end slope. Where the bulbous tip, we're going to reduce that. We're going to narrow the nasal bone. We're going to lift the tip. We're going to reduce the hanging columella. So I kind of break it down into components. And that patient is going, yes. No, I want to leave that alone. No, okay, we're going to leave the tip alone. No, you're fine. And so we walk through all the components, and then we come to a game plan. And then I'll talk about the process, which is it's general anesthesia, it's closed rhinoplasty, the incisions are on the inside of the nose, the stitches are dissolvable, there's no tampons or painful packing placed inside the nose. We talk about the anesthesia, the facility where it's done, which is right next door to our office. It's an outpatient surgical facility, which is Medicare certified for patient safety and comfort. You were not going to the hospital because you couldn't afford it, taking patients to the hospital. And we talk about pain and discomfort, which is very minimal because we don't put packing in the nose. And we talk about pre-op care, post-op care, and then the staff talks to the patients about scheduling or financing and then scheduling, financing, and then anything else that they have questions.
You guys do take financing?
Correct.
Good. Do you take care credit or do you do private lenders?
The newest one we've started with is called Cherry.
Cherry, yeah, I'm very familiar with Cherry. We use that
we've
too.
been very pleased with that platform.
Yeah, Cherry's great, especially if you do it through Pally. There's no processing fees, I believe, for you offer it. So if you can throw in some Botox or an allergen product while you do it, you're really good for the patient. So we can talk more about that.
Yeah, I have a question. Have you guys ever had filler?
No.
Never.
I have filler once here in a bridge of my nose, like just a little bit, like a tiny, like 0.3 ml.
Botox, that's clear.
No. Just because I want my little nose, but this was like in residency.
We don't use neuromodulators.
Love it.
Do you use skincare? Do you wash your face?
Sunscreen. I do take showers on occasional.
Sunscreen, I mean,
scrub in. So sunscreen as a must. And then I use retin-A, like retinoids and stuff.
Yeah,
so that's about it.
Okay.
Yeah.
That's great.
Yeah.
Okay. Well,
Never had a rhinoplasty?
never had a rhinoplasty. Just like I didn't break.
You guys do.
like you're a poster child of nice care.
I know.
Requirement. Yeah, that's pretty nice noses.
Thank you.
Yeah.
Thank you.
Yeah, keep it up.
So, as a consumer and a patient, what would be a red flag? In terms of, I went to consult with somebody and they told me this is not, what's a red flag for a patient? Like run away from that surgeon. Don't do it.
So if they're telling you there's not, like, I have 0 revision rate or 0 complications, that's a red flag.
Because they're lying.
Correct.
Liars. Okay.
You want to make sure you're going to a surgeon. First of all, rhinoplasty is the most difficult operation to do in all of cosmetics.
Is that why you chose it?
Yes. Because
That shows us. I can wait.
Overachievers.
figure out how to do. That's why I had to go to the cadaver lab to figure out how to do.
This is such a good story. I'm pretty sure you're just sitting there on those dead bodies. You're waiting for a little bit of music on. I don't like cadavers. Little red hot chili peppers in the background, beans to the drum.
You want to go to a rhinoplasty specialist because it's a very difficult procedure. So you want to look at the doctors, the surgeons' rhinoplasty photo gallery and make sure it's extensive with a lot of natural looking results. That's all. Make sure that rhinoplasty itself is a discipline. There's textbooks this thick, many of them. And, it's just a discipline that you really got to do a lot of to get really good at this procedure.
And I have to say, your before and afters on your socials are really amazing. And
So good.
And it's really like what I want to see whenever I've ever selected any kind of aesthetic procedure. That's what I want to see. I want to
Just
see
before and afters.
Yeah, because you know what you're getting. And I know because it's very challenging to get patients to agree to share the results.
Yeah, how do you do that?
That's,
Well, that's a good question because most people do not allow us to use their before and after photos.
I mean, they
So it
won't even
takes-
let us use them for lip filler. So I'm like, how are you getting all these rhinoplasty photos?
we do a lot of rhinoplasties. I mean, a lot. And so, but we just ask. I mean, patients are happy. They're happy to give but
it's a big deal. It's very vulnerable.
It's a very, very age specific. So I would say somebody over 40 is not comfortable giving us.
Millennial Gen Zs are like, put me on your page.
Yes, right. Yeah, they're much more comfortable, and they also realize that it's like, oh, I found you through Instagram, so I'm going to return the favor. This will help to me to research my surgeon, so I'm actually going to return the favor. So it's very altruistic in that sense. It's so, like, okay, I'm going to help other prospective clients to see what I went through. So it's really cool.
Yeah, I agree. Yeah,
website.
Like it's interesting how they're open minded.
The rhinoplasty before and after photo gallery on our website. We don't even take those pictures until 4, 6, 8, 10 months or a year after the surgery. Well, think about that. If you've got it takes 6 months or a year to get somebody through the process before you can get a set of after pictures. And most people don't give us permission. So you have to have you have to have a lot of volume of patients to be able to get a big photo gallery.
Yeah. It's so funny because, yesterday we interviewed Dr. Austin Hayes, and one of my very good friends had a breast augmentation from him. And she was offended that he didn't post her before and afters. So I was like, oh my God, it's like me as a consumer and as a patient, I would want you to tell me as a surgeon, I'm so proud of this. I'm so happy with how your results turned out. Can I post you? I think that's kind of where we're at with the younger generation, right? Where you should ask everyone.
And she's like our age. She's
like
38.
Was he not proud of my boobs? Were they not great? I actually thought the same thing. I had a BBL, and I thought my results were literally fantastic. I was like, oh my God, this is such a good before and after. I had sent the surgeon like really good before and afters, never posted them. And I was like offended. So I think that there's something to be.
This is marketing.
Exactly. But there's something to be said about that like you really should ask everybody what's the worst you're going to get. No, I'm not comfortable. No problem.
Yeah.
On the social media side, we actually post more of the just taking the cast off.
I love those videos.
Just capturing the patient's aha moment.
Yeah,
I know how you're.
It's an emotional response. And a lot of these pictures, they cry, they break down, because this has been something that's been on their front burner for years and years and years, 10 years, 15 years. Finally, we take that obsession off the table. And now we just make their nose blend in, and they just start breaking down crying. And with permission, we are able to capture that. But most patients do not let us use it.
So what is the typical downtime recovery time for your patients?
So the nice thing about closed rhinoplasty is that recovery is very quick. I would say people are ready to go back to work in a week or so. We work in a tech town, so some people work remotely. They can even go back on their computer and do emails or do Zoom calls off of camera.
So we get it like on a Monday and be back the next Monday, potentially.
Yes. Yeah.
Cool.
And even if they have a little bit of bruising, you can cover it with makeup, and it's not a problem at all. It's very quick recovery. So returning to exercise and things like that is about 2 weeks. Aerobic exercise, lifting weights, probably 3 weeks, because we don't want to raise the blood pressure or cause a nosebleed. And then swimming. Yep. Swimming and contact sports will probably wait a little bit longer. So for swimming, I'd probably say 4 weeks. And contact sports, where you can get smacked in the nose, probably 8 to 12 weeks.
Or just take that off the table. Who does that anymore? Really?
Yeah. Too old for that shit.
Come on, roller derby.
If you're
Illegally fly.
if you're spending thousands of dollars on a rhinoplasty, we should stop with the contact sports.
Yeah.
You'd be surprised. You'd be surprised. I spent, in the military, like every other guy was doing MMA or boxing, and they're like, when can I go back to grappling,
Don't get a rhinoplasty. There's knows you too.
Yeah,
I think about it like I'm gonna have another child, and then I'm gonna get my mommy makeover. Like you don't do it before like messing things up.
So when can you expect long-term results, and do noses change over time? Do they grow back?
I think we say that the long-term result is at least a year or two. Your nose will continue to change, and the skin soft tissue envelope does shrink wrap around the new construct of your nose. And as we age, our skin changes also. Our skin becomes thinner. We lose our subcutaneous fat to some degree. You can develop wrinkles, pigmentation. All those things can happen irregardless of you having surgery or not. So there are going to be some changes. Naturally, your nose does tend to elongate with age. And, I think the rhinoplasty does reverse it to some degree. So I think we even have some patients who I saw a patient just recently who said, I don't want my dad's nose because I'm looking at my dad. He's in his seventh decade of life, and I see what's going to happen to my nose, and I want to prevent that. So some people are actually getting preventative rhinoplasty nowadays to reverse or prevent some of those changes they're seeing.
I hear that as well. No, I got my dad's nose. And I use it. Well, thanks, Dad, right? Yeah. Thanks, Mom. I got my mom's nose. Yeah.
We hear that a lot in injectables. It's actually, I would say, one of the driving factors what people come in for consultation with Botox or under eye stuff. I looked at my grandma the other day and I booked a consultation. Still, even though I didn't want to look like that, it's kind of sad.
I've shared this with you before many times, Jesse, but there was this moment where my mom was just staring at me, and I'm like, what? And she's like, you don't look like us. She took me to get my first rhinoplasty because my nose was soaked up from injury that she was like, you don't look like my kid.
Yeah.
So she was the one that drove me to the consult to get it fixed because she was just like, I'm not my kid.
Oh, it's funny how those generational biases that land you in a surgical or injectable chair.
Let's do a hot take in rapid fire. First thing that comes to mind, no explanation, okay? Your favorite celebrity with a rhinoplasty.
Wait, do you guys want to take a shot? No, you can't. You're surgeon.
No,
You can't. You're surgeon.
I'll pass.
Oh, wait, did you know that you're in Toxland?
Yeah.
You gotta do something toxic.
We'll bring Botox next time.
So says the guy who's never had one unit.
Yeah. Why didn't you let us do your Botox on air? Come on, you guys.
Yeah.
I'll be your model.
Okay. Really? I got some GLP-1s. I don't know what those will do for you, but
I'll definitely do your Botox when I'm not in talks.
I did it, but I toxicated. Okay. Favorite celebrity nose job? Dr. Joe.
Oof, that's a tough one. Probably Jennifer Aniston's.
That's a good one.
Oh, yeah, that is a good one.
Michael Jackson. It's my favorite of the 21st, and it's the first one. It's because it gave such a bad name to the
So
procedure.
you're always going to be good as long as you don't do that to people.
No, it's just people. We don't want to give patients ski slopes, Miss Piggies, or some crazy looking nose. And Michael Jackson just kept going and going and going and had many multiple procedures, and it gives rhinoplasty a bad name.
But it's your favorite.
No, it's not my favorite.
Okay, so you didn't answer the question. It was me. All right, trendy nose shape or timeless nose shape?
Well, we always talk about the trendy stuff. You go on Instagram and you have these on-the-table results from other countries. They're like, you can poke somebody's eyeball out with that nose, and so super pointy, upturned tips.
Trendy or timeless?
Timeless.
Timeless. I'm always for timeless.
I always tell patients you do not want to have a tilted up ski slope or Miss Piggy nose because you'll have rhinoplasty written across your forehead for the rest of your life.
Yeah. Okay,
Yeah.
Grace Kelly or Bella Hadid?
They don't know who Bella Hadid is. Yes, they do.
Grace Kelly.
Grace Kelly.
You don't even know who Bella Hadid is.
I've seen her picture.
No, you didn't. What does she look like?
Cute little blonde.
No, she's like a 5'11" brunette.
Busted, I've been close.
Liar, I know you. This is probably obvious. Nose filler or rhinoplasty.
Rhinoplasty.
Rhinoplasty. You got to be careful with the fillers.
We don't do it.
They can create something called skin necrosis, where you get a big dead spot of skin on the nose, and it's a disaster. So
I would just need a facial transplant.
I think interested in doing.
I think there is a room for filler in certain situations. For example, if somebody does not want to have surgery or not a candidate for surgery for health reasons otherwise, or just wants like a minor little thing, I think there are some situations where you can use a filler. But you have to know your anatomy. You have to stay midline and to be really careful. You know, pull back that plunger to make sure you're not in an artery. Sometimes you can have like little secondary indentation or minor defects that you can fix with a filler. So let's say a patient doesn't want to have a revision. And you can sometimes camouflage those, and I've done that in the past. In rare occasions, I use a little bit of filler to kind of fill that area out. And so, yes, you can use a filler just judiciously, and it can also stretch out your skin. So you can camouflage things with a filler. You can, but you're always making nose bigger. You're never making nose smaller. So that's the thing with the filler. So you're stretching that skin soft tissue envelope by putting more volume in there, and that skin is going to have to contract at some point. So if you stretch that skin and that filler goes away eventually, you can have some laxity in the skin. Also, what if you have to have surgery eventually? That makes the surgery a lot more challenging because you've now have this extra volume in there. And so I'm very judicious with the filler in the nose.
What filler would you use if you needed to do?
I usually use Restylane. Restylane.
so it's reversible.
It's reversible. Yeah.
And like, how often do you have to do that?
Pretty rarely, yeah. My choice, if I have to do a little touch-up, I usually do a touch-up revision with a crushed cartilage or fascia graft because I can place it precisely. I'm not going to have that bubble-up effect because, as you know, in certain situations, like in a scar, let's say you have a puckered scar and you inject a filler, sometimes you get the donut effect where the filler goes around the scar and actually amplifies the depression instead of fixing it. So that can happen on a depression in the nose as well. So you have to be really, really careful.
So for other areas of the face, I would usually subcise first with the needle.
Yep.
But I would imagine that that's almost impossible in the nose.
Not impossible,
Dangerous.
but
Difficult.
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 And what precautions do you take if you are putting filler in to prevent blindness? I hate to even say it out loud,
so-
like saying Voldemort.
Yeah, I mean, I think if you stay midline, you're less likely, not a zero chance, but less likely to hit an artery. Just pull back that plunger. Small aliquots, move the needle. Don't put big boluses of filler in the area. Those things, and we don't really know. I mean, the filler-related necrosis is such a complex topic. We don't know if you're actually directly injecting it into the vessel, or you're just compressing the vessel and you're cutting off the blood supply. There's a lot of stuff we don't know about how it happens. And so, obviously you have your rescue kit, available if you're in trouble but again, it's, if it's done pretty infrequently, it's unlikely that you have a problem.
So I am bothered by my little bulbous tip. And I had a filler rhinoplasty about a year ago. I'm pretty happy with it, but I think I'm still going to want a little bit of surgery. So would you dissolve it first? What would be your approach to that?
It's been a year. Most of that filler is probably dissolved. And just the opening, with going up through the nostrils and doing surgery, there's occasionally we'll see a little bit of filler in there, but it's really not going to affect it much.
Do you feel like it migrates or?
If you put it here, it can migrate this way. I have seen it in the tip, but I think in the tip it tends to stay reabsorbed.
What does it look like when you get under there?
Clear gel.
Like you can
I'll show you a
catch
picture.
it?
We just had one recently for chin. We saw it looks like a blob. Yeah.
I have a whole
least
lot of chin filler.
So we were doing a chin implant placement a couple of weeks ago, and opened the chin up, and like this whole big blob of fluid.
Yeah.
Did you just like pull it out?
Yeah, just pull
She
it
said,
out.
like, oh, I've had this amount of syringes. Or,
Oh, there were several syringes. All blobs.
Did you disclose I'm sorry you had operated?
No.
She is. People come in and they're like, I've never done anything to my face and I want cheek filler. And then we have like punctured an implant.
yeah.
It's like, you have cheek implants. Wow. What a weird thing to not tell someone.
Can't go to poor historians, or they just like,
Forget about it. They just forgot.
How could you forget you had an implant in your cheek? You know what I mean?
I forgot what I ate for breakfast yesterday.
I know you had a hot dog for breakfast today. That was today. That was all. What's the wildest request you've ever received? Has anyone asked you? Like,
I did a rhinoplasty on a guy from here in Oregon, and he had a fantastic, damn near perfect result. I mean, it was so good. I said, listen, I would be, with your permission, I'd be glad to put you on my website. It's that good of a result. And he goes, no, I wanted to look like Batman. I go, what? That's what he said.
Batman?
Batman.
What does Batman look like?
I don't know.
Keaton or Christian Bale?
With Batman.
Great looking nose, but he wanted it to look surgical.
What did you say?
I said, no, leave it alone.
Batman.
That's right. Yeah.
Fascinating. Yeah.
So again, it's about, wanting what Dr. Joe and I want to do is give patients a very natural looking nose. So it doesn't look like we've ever been there. It's the nose just blends in with your facial features, and it's balanced in all three dimensions, all the way around. Oh, and by the way, it breathes well. Mm-hmm. But I don't want people to look like, Cruella or somebody else or some great.
So if I have to go like this, take a really good deep breath out of this nostril, do you feel like that's a reason to operate again?
You may have a bit of a collapse, either internal or external collapse.
You looked at my nose with a flashlight and you told me it was deviated.
Yeah, the septum could be deviated. You could have nasal valve collapse. I think we need to do some further examination, determine what's causing it.
Why don't we do this?
Maybe in the office, not in the restaurant.
Okay, why don't you do whatever you need to do and record it, and then we'll put it on Babes and Toxland.
There you go.
Oh my.
Okay.
Wait, can I go to consult too? Okay, so
Consult. Jessie never makes it about herself, and she needs the time.
no, I
want you to have it.
I just want to hear what they have to say. I love my nose. I'm really happy with my nose,
But it's like a family note.
I want this to be ever so slightly smaller. So what would you do with someone who came in and said that? Just the tip. Just the tip.
You guys don't even get that joke. You're too old.
Give me a big smile. Well, you can attempt to try to do only the tip, but I think you're going to need more of a full rhinoplasty.
It's okay.
And the reason is because if you look, yes, we can go in and sneak out a little bit of the cartilage in your tip, but the cartilage in your tip right here is actually causing a part of the dorsal profile. So when you take the tip, you're looking at, you have to look at it in three dimensions, not just front on. But when you take a bit of that cartilage out, you look at it from the side profile, the damn thing's out of balance. So now you got a bigger hump, or you got to shave that down. Then you got to lift the tip maybe just a little bit because you have your tip droops a little bit when you smile because of the little ligament right there. And so again, it's all about three-dimensional. And then when you take cartilage out here, you're going to be a little more pinched right here, and that's where those little spreader grafts come into the fest.
I'm gonna just.
That's a great answer.
You actually have a very difficult ask because your dorsum, your bridge is perfect.
Yeah,
you don't have a bump.
Perfectly straight. It's beautiful.
So you're asking to fix only one part, and in the nose, everything is interrelated. Your tip is interrelated to the bridge of your nose. Your tip is interrelated to your upper lip and your eyes, and so all those proportions have to match. And so that's what we're looking at, about 150 different points when we're analyzing your face and nose and trying to match those together. So it's not always that simple. You can modify the tip, but sometimes you have to adjust the bridge and you have to adjust the rotation, the projection of the tip, in addition to just making the tip smaller.
It's so
To make it fit.
rare. It's extremely rare to only do just the tip. So I call it a slippery slope. Once you, and, you know, do the tip, and then all of a sudden the hanging columella dips down or the tip dips down. You got to do that, and you get it. Then it doesn't. The bridge doesn't match, or you got a bump here, and it's just one thing. The one maneuver leads to the next one, leads to the next one, leads to the next one. That's why you almost really have to do, even though you're not doing much here, you're only maybe shaving 1 millimeter here, 2 millimeters there, but you just, as a standalone procedure, as a tipplasty, it's almost extremely rare, once every 5 or 10 years.
That's a really good answer.
Yeah. And how long would the surgery on Jesse take you, and what would the approximate cost be? Those are things people are really...
Surgery takes about an hour to hour and a half. And that's the nice thing about closed rhinoplasty. That's another main difference between open and closed rhinoplasty. On average times are about an hour and a half, especially if you're doing some internal work to fix a deviated septum. It's probably closer to an hour and a half. If it's just the tip and maybe minor modifications of the bridge, is about an hour. So,
And you guys don't have to talk about costs.
The cost is located on our website.
it's a look at our website. It's transparent. So go on CNFfacial.com and our prices, PortlandFacial.com, and the prices are listed there. Yeah.
Very rare.
But what are
things?
And we're very true to our cost.
It's about $11,000.
That's great. Yeah.
But that includes the operating room, that includes the anesthesia, and that includes with general anesthesia, and includes the professional fees for us doing the procedure, and
It's less than I paid for either of mine.
and the post-operative follow-up care for a year.
Interesting.
So do you think I should move forward?
I don't want to talk you into anything.
Yeah.
Yeah,
She's a good surgeon.
That is the best answer.
Try to talk her out of it, and if she still loves it, then you're game.
Yeah.
So tell me something toxic. Anybody have a toxic story for me?
Oh, you know I did.
let's hear it.
No, I want to hear the surgeon's toxins. Sorry, mine are boring compared to...
Give me a for example. I mean, what in life or in...
Somebody the other day asked me, like, what's the happiest I've been in the last 2 years? And I was like, oh, hands down, when my fibula, is that a bone?
Yeah.
Was broken.
You were the happiest?
Happiest.
Because you
Nobody.
didn't have to go to work.
I didn't have to go to work. Nobody bothered me. I got to lay flat in bed. People catered on me. I had an excuse not to go places. I got to be pushed around in a wheelchair, and I milked it for everything it was worth. I was having my friends push me around in a wheelchair around a park with a White Claw. Like, I was just soaking it up. Like, how toxic am I? I let that stuff linger because I was like, maybe I should break my other leg. Like, that was the most fun I've had in a long time.
Yeah. I'll tell you a funny story. It's unrelated to healthcare at all. Well, so in my previous life, when I was working in a large multi-specialty group, we have about 1,000 providers. And so I kind of got interested in administration. I thought that was cool, and I wanted to learn about something outside of medicine. So I was part of the physician or provider compensation committee. And when doctors talk about their money, about their paycheck, they get very, very upset.
It's literally
anything
my job.
changes,
So it's
you know.
providers about their pay.
So I had to basically manage a group of 1,000 providers, and I became a lead of the compensation committee. So I had to hear all the complaints about doctors with reduced salaries, or they missed their bonus, and they would sing their sob songs, and we had like this committee, and we would discuss it and, you know, make decisions. And it was, you know, had to, you know, if you deprive somebody of their money, you know, they're not going to be very happy with you. So that was a very difficult job, and I did it for a few years, and then I left, and I thought, man, that was the most difficult job I've ever had in my life. Well, a few years later, my son started playing hockey, and I got a chance to be an assistant coach, and so one of the seasons they asked me to become a head coach because one of the people dropped out, and these are all volunteer positions. These are not paid positions. Yeah. And so this is just the in-house league or just like a little travel league, but not very high level. Mm-hmm. But I had to deal now with the parents of the players.
Fun.
And this was only a group of 10 parents, but I can tell you that was by far the hardest job I've had to deal with. And that this was not even close to dealing with difficult personalities of
Positions, 1,000 positions. Spill the tea.
Yeah.
Say their names. We'll not do that, yeah.
Yeah, see, we'll do a play around when it comes to the kids' names.
No, can't do that. Yeah. But that was, I know I'm not going to be the head coach of it.
Tell me
The hockey team anymore.
Tell me about your wine.
Oh, I've been an amateur winemaker for probably 30 years. Started with a buddy.
How are you an amateur at anything after 30 years?
Well, I don't sell it for commercial production.
Okay.
So I give a lot away as gifts and Christmas gifts and dinner parties.
Does anyone ever tell you it tastes like shit, or they all just say it's the best thing they've ever had?
Well, I've had a couple of bad vintages that they're like, it tastes. And even 5 years later, it's, oh hell, this tastes like vinegar, and pour it out.
So you're growing the grapes.
Well, so what I do is just right now for the last 10 years, I've just been buying grapes like off of Red Mountain in Eastern Washington. Usually Syrah or Cabernet, but what I do is the professional winemakers will actually now technically make the wine because I just don't have the time. But I do the blending trials, and so I'll get 6 lots of different kinds of Syrah, different clones of Syrah. Let's just say example Syrah. And one time the winemaker I picked out, we had 6 or 7 Syrahs, and I picked, throw it, nope, yes, nope, yeah. Then 30, 70, 70, 30, 90, 10, 10, 90, 50, 50. That'll do right there. Mix it up, blend it up, put it back in the barrel, taste it in 6 months, and the winemaker comes back. He goes, "Holy crap!" to the owner. He goes, "Do you know what this wine? This should be $100 bottle of wine. How the hell did they come up with this?" And I go, "Just mind my own business." But no, we had picked a blend the blending was better than what he was producing at $7 a bottle.
Noted.
And he's like, and we just snuck one right underneath his nose. And he's the professional winemaker. I'm just the blending guy.
So what's it called?
That's the whitest thing I've ever heard.
What's it called?
It's the wine label is called Fucker. And that's spelled Phukar.
Okay.
It is a chimera or what happens is that when a pheasant fraternizes with a chucker, you get fucker. And we put it in the Magnum bottles. That's big fucker. And I put it in the little bottles and little fucker. And we even have a beer label, cold fucker.
The next time you come to town, will you please bring me a big fucker?
Yes, Harry.
Thank you so.
I'll teach a little fucker.
And
I'll take the cold one.
Perfect. Well, thank you guys so much for being here, Dr. Portuese
Thanks for having us.
Dr.
Say it, Drew. No, say it.
I can't say your last name. Sorry, I can't.
Say it. Just try. Just try.
Sir.
No. Okay. Like the theater orchideas and shit.
Just it's your part. You say it.
Schvidler.
Close.
Oh, that's not it? What is it?
Schvidler.
Schvidler on the roof.
Schvidler on the
Yes.
So Dr. Joe
right.
Schvidler.
Yeah.
And Dr. Bill.
Oh, you
Portuese.
forget it, you guys.
Okay. You can find them in Seattle, Washington.
Oh, I'm going to find them.
Highly recommend. Best nose jobs I've ever seen.
Thank you.
Thank you.
You're welcome. Thank you so much for coming down here and being with us from Seattle. It was a pleasure to have you in Toxland. And until next time, stay toxic.